I'm Luanne Willingham. This is my airway management video. I'm going to demonstrate placing the patient in a stable position, triple airway manoeuvre, APP ventilation, insertion of an oropharyngeal, nasopharyngeal airway and use of the laryngoscope. Filmed on the 2nd of October 2013, safety precautions, gloves and goggles. I'm going to demonstrate a triple airway manoeuvre. Firstly, I'm going to place a pillow blanket 2 to 5 centimetres thick underneath the patient's head. This is because in an adult the head is slightly smaller than the shoulders, and this is to assist with maintaining a straight airway. I am now going to do a head tilt. I'm going to place my hand on the patient's forehead, thumb pointed down to the nose. I'm going to slightly tilt back and press down. I'm then going to do a chin lift. Using my thumb and my index finger, I'm going to grab the patient's chin and I'm going to pull up and down and have a good look of the airways. I'm now going to do a jaw thrust. I'm going to use fingers 2, 3 and 4, place them underneath the mandible. I'm going to place my thumb on the zygomatic bone. I'm going to place my index fingers on the chin. I'm going to thrust up with fingers 2, 3 and 4, and I'm going to push down on the chin with my index finger and have a good look and inspect for a clear airway. You need to be careful when doing a head tilt that you do not hyperextend and cause kinking in the airway. You also need to be careful when you are doing a jaw lift that you do not press with the fingers and include the airways underneath the mandible. The rationale for this is to assist with keeping the airway straight and open and to be able to give the paramedic a good clear look. I'm going to demonstrate oropharyngeal airway manoeuvre, or OPA. First step is to make sure you can size this accurately as possible for the patient. You do this by placing the flange of the OPA at the patient's lips. You want the curve to follow the angle of the jawline with the tip ending at the mandible. When you place this in, the arch needs to be facing towards the palate of the mouth. You place it in at halfway, you turn it 180 degrees as you continue to push in. You want to make sure that it is resting just above the patient's lips and you haven't actually pinched the patient's lips with the top of the flange. You need to be careful this is not to be done in patients that are conscious or semi-conscious, as it will provoke the gag reflex, and with patients with trismus, if this happens at any time, you must remove the airway immediately. The rationale for this is to help keep an open and clear airway, providing easier access if you need to suction, and to keep the tongue pressed back off the airway to help maintain it to be clear. I'm going to demonstrate APPV ventilation of a patient. I'm going to ensure that they are in the supine position and they already have an OPA inserted. I'm going to roll the face mask from right to left across the patient's face, and with my index finger and my thumb I'm going to grip in a C position the mask, and I'm going to place my other 3 fingers under the mandible to ensure an adequate seal. I'm then going to ventilate the patient at 12 to 16 breaths per minute, ensuring adequate ventilation. You want to ensure that when you do this, you do not overinflate the bag, causing damage to the lungs. You want to do this at a volume of 10 mL per kilo to the patient. I'm going to demonstrate using the laryngoscope. I'm firstly going to ensure that the bulb is screwed in and the light is on. I'm then going to place my right hand on the patient's forehead, my thumb pointed towards their feet. I'm going to ensure that the patient is in the supine position and their head is in the sniffing position. I'm then going to slide the laryngoscope down the extreme right hand side of their mouth, sliding across to the left. I'm going to place the laryngoscope in the follicular groove in front of the epiglottis. I'm going to grip with my thumb pointed towards the patient's feet, and I'm going to apply some pressure pulling forward until I have a clear view of the patient's vocal cords. If at this point there is an obstruction, I would use a McGill's forceps to remove it. You want to be careful when you're doing this procedure that you do not sever the patient's epiglottis, and the other error commonly that occurs is chipping off the patient's teeth. Stable position. Kneel at patient's hips, ensure they are in the supine position, check pockets. Far arm outstretched from shoulder, near arm across chest. Near leg flexed at knee, hands to hips and shoulders, rotate. Draw leg up for stability Extend head, rotate to the ground to ensure clear airway and drainage of fluids and vomit. Top arm extended in front of patient's head. Error, do not do this in patients with suspected spinal cord injuries. I'm going to demonstrate inserting a nasopharyngeal. Firstly, I'm going to ensure the patient is in the supine position with their head in a sniffing position. You want to make sure that this is accurately measured for the patient by placing the tip of the flange to the tip of the nose and the tip to the earlobe. You want to lubricate this with some KY jelly before you insert. I'm going to look at the patient's nostrils and choose the largest and the clearest. I'm then going to place in at 90 degrees from patient and slowly rotate anti-clockwise and clockwise at 45-degree angles. I'm going to do this by inserting some pressure until the flange is resting just above the patient's nose. You want to ensure that you do not do this on patients with middle facial fractures, as you could pierce through to the brain. You do not want to do this on patients with expected brainal injuries, as it could increase the ICP.